All right, guys, good morning. First off, for everybody that was here last week, I'm so sorry that I'm subjecting you to a very similar talk about emergency medicine. So we'll try to flip through and sort of hit the high points and talk more about the sort of the why and how you get there. Just because when I was in high school, I had no idea that this is what I wanted to do. I had thoughts really about medicine. I was thinking far more about doing something more akin with international relations. I grew up in Annapolis, Maryland, on the other side of the country. For a while when I was growing up, my parents moved us over to England, and so I lived over in Durham, which you can see right there. It's big because that's where they filmed actually most of Harry Potter. And I went to my local public high school, which Annapolis is not that big. There's only one public high school, and that's Annapolis High. I ended up, I had no idea I wanted to do medicine or anything else like that. So I studied international relations and Spanish, and I did that at Washington College, which is out on the Eastern Shore of Maryland. And up through, other than a couple of trips overseas when I was young, I hadn't really ever left Maryland until college. And as a result, I was really lucky because one of the reasons I chose Washington College was because it let you study abroad. So I studied abroad for a year and a half out of my 4 years there. I got to go to South Africa, I was in Spain, and I was in Ecuador. But what that meant is that after college, I worked for USAID and for the State Department, and then ultimately joined the Peace Corps, and it meant that I had to take undergrad again. And so I came back, and again, I went back to Maryland and was at Hopkins for a year before I went to med school at the University of Michigan. And so it was something that, for me, I never had no thoughts about, what does it mean to be a non-traditional student or anything else like that. But I think the biggest thing is that, even if you're doing this and you're thinking about med school, it doesn't mean that you have to go straight through. So I worked for USAID, that's the Reagan Building, downtown DC. I was there working in the Central American Affairs Division. And then at State, I was really excited. I had classed out of my Spanish, so I thought that it was going to be a lot of fun somewhere in Latin America. And they sent me to Calgary, Canada, which is basically the Texas of Canada, which was great. I had virtually no use for Spanish other than occasionally getting to process visas with folks. But I did get to meet John Malkovich. That was kind of interesting. And all of the hockey players for the Calgary Flames, because most of them although they were mostly all Russian. And then in Peace Corps, I was in Costa Rica. I lived right up on the border between Costa Rica and Nicaragua, a little town called Cuatro Esquinas. And it was super interesting. This is how I got around. I owned a horse. This was one of the families I lived with, and that's my class. Please don't take photos of that. That was, at least my haircut's mostly the same, although I still had more hair and less gray. And I was there for almost 3 years, and then when I got back and when I started at doing undergrad again, I was more and more interested after seeing a lot of the DOTS therapy that they were doing both with malaria and then also with tuberculosis, and how they were practicing rural health care. And so the only real option I had was I joined the Woodlawn Volunteer Fire Company, which is just outside of the city of Baltimore, because Baltimore City itself didn't have any volunteers, but all of the surrounding county, which literally runs right into the city, did. So I got to work with them. In med school, I was at University of Michigan, and I kept trying to go abroad. So I was in Peru on and off for the first 2 years. And then, unfortunately or fortunately, depending on how you look at it, clinical work tends to take over your life. Dr. Pierre can talk about this. And one of the best parts about trying to figure out that balance is figuring out what else you like after getting through all the clinicals. And one of mine still is teaching and then getting the international flair. I'll get to how I manage that. So this is me on match day. This was everybody in my group that did emergency medicine. Dr. Latimer is now the Associate Director of Medic One here. He was a University of Washington grad. And we are now still colleagues and get to pester each other at odd hours of the night when Medic One does things that one of us either likes or doesn't like, which is fun. I did residency just down the road at Madigan Army Medical Center. I joined the Army after I moved through the Peace Corps. It was, I guess, kind of weird if you think Peace Corps to the Army. My country director was a former SEAL team leader. And we had talked a lot, especially during my last year in the Peace Corps, and he had said, hey, you should think about Navy or Army. I'd grown up in Annapolis. I couldn't really handle the Navy any more than I'd already grown up with, so I joined the Army and was at Madigan for 3 years. This is classic. This is Dr. Pierre can potentially tell you about this, but this is what the attendings did when I was a resident, which fostered great independence and decision-making authority on my part, which was great and also terrifying. This was when Tim Curlet's there, so I was probably a second-year resident, which means I had half of the emergency department overnight by myself. And the goal was then, don't wake up Dr. Durbin, because if you woke him up, you got in trouble. The Army is different. It was good. It made me a much better physician, if not at sometimes. Although Dr. Mescal, who is now one of the head toxicologists for the military, was actually a fantastic senior and chief, and so he basically could run everything by himself, which he did. After Madigan, I managed to get to Special Forces. That's where I was up until the end of 2020, which meant that I had to do dumb things like jump out of an airplane using World War II technology, which is why my left knee can tell me when it rains, and why I still don't really have any abductor muscles now in the left part of my leg, but that's another story. We got to do all sorts of fun stuff, though, that looked really cool, like jump out of Blackhawks, jump out of C-130s. I couldn't find one of my own pictures of a C-17, but we also got to jump out of one of those. That's the really, really big, well, not the biggest one, because that one can't slow down enough to not rip your legs off when you jump out of it, but the C-17 is the second biggest one. I also ended up going through the naval course for diving as well. That's my dive partner. He was great. Evan is now an anesthesiologist at Balboa, which is the big naval hospital in San Diego. Evan's also, if you can't tell in the photo, about 5'5" by 5'5", which is really great when you're 6'3" and they're having you carry a boat, which just meant that Evan ran around like this. But dive school was a lot of fun, sort of type 2 fun, but that's also a lot of residency. And taught me a lot, especially about hyperbaric medicine. And so what I ended up getting out of both of those was both hyperbaric and hyperbaric. So how to press people, how to deal with all of the different decompression illnesses. And then on the flight surgeon side, we worked with sometimes having things like we had a Air Force pilot that was overhead of us, lose pressure in his cabin at 45,000 feet. He fortunately did not crash his aircraft or completely lose consciousness. He was able to bring it down to the ground, which is amazing. He was flying a Raptor at the time. And then as soon as we got him to the ground, he basically had to immediately be pressurized because of, with type 2 DCS, just like Ava was showing you guys, all those bubbles then form actually inside the spinal column. And that's what you see with those rapid depressurization illnesses, which is totally different than diving. With that being said, one of the best parts about the Army, aside from getting to do a lot of international healthcare, was the training. And so this is me. This is what 18 Deltas, my medics. We would train the Special Forces medics to roughly the same procedural level as what we'd now consider a physician assistant. They could do everything, including tube thoracostomies with me. And then one of the biggest things that we were moving towards as everything went down in Afghanistan was what we called prolonged field care. And so this is definitely not inside of a truck and not in Latvia, but these are 2 simulated combat casualties that we had taken, essentially prepping for what is currently going on in Eastern Europe. And then we also did a lot of dental stuff. It's why dental work in the emergency room is still one of my favorite things. It's because it's one of the few things that we could do where we didn't need as much follow-up. And so while we always had a dentist with us and a dentist would come out with us, we'd always train all of the 18 Deltas how to do everything from fillings to tooth extractions. And there are things that I used to do on a regular, not in the United States, but outside the United States on a regular basis. So when you deploy, this is what everything looks like. This is your operating table. You can see it's got these huge bags underneath of it just because, unfortunately, trauma, especially combat trauma, is very bloody. And you can carry everything. The way we packed it all is we could put 2 of these up-armored ATVs into the back of a Chinook, a CH-47, and we could go anywhere. And that whole thought of that is that you want to be able to get from the time somebody gets injured to the time they get to a surgeon. It's 1 hour or less. And then this was one of our emergency rooms in the field, and you can see these are on the floor. This is where each of the beds go, and the beds are all on wheels. And so basically, you receive a casualty from the helicopter, and you wheel them directly in. You do your first survey, and then you're re-triaging however many. You could take four casualties at a time to then get into the operating room. And then this is usually everything that I carried with me. Most of my job then, if I wasn't directly in the ER, was all the coordination. And so this is what it's like. This is basically all the crap. There's so many cell phones. Oh, and urine bottles. Sorry, that's unfortunate. There aren't any bathrooms anywhere, so if you wake up in the middle of the night, this is what you have to deal with. That being said, so this is what it looks like through NVGs as you start to get ready to go out. This is us going out on mission. In this case, it was a Afghani Special Forces colonel that had developed a pulmonary embolism. He then, of course, got taken to a hospital that was then controlled by the Taliban. And so we were requested to work with one of our teams on the ground to get him to move out of the area and get him back to a U.S.-controlled hospital. So this is us. We're moving out. This is what our EKGs look like in the middle of the night. And this is how you would think everything would be touchscreen at this point, but there's this definite lag, especially between the government and the civilian world in terms of how you get stuff back. And so that's where that came from. With that being said, then this is this is during the Battle of Sangin, which is in the southern portion of Afghanistan, in Helmand province, which is right next to Kandahar. Kandahar is right out over here, and that is the home base of the Taliban. This is what Sangin looked like during the battle, and this is one of our interpreters, Johnny, who was actually really lucky because right as the round hit him in the back of the head, he had his mouth open. And so the sniper round exited his mouth and only chipped one of his teeth. But that pressure wave that comes with a sniper round, because the sniper rounds are usually about this big in terms of the caliber, ended up causing a big pressure behind his eye and the development of a retroorbital hematoma. And so to get that released, those are my hands right there in the purple, doing what's called a lateral canthotomy. And so you go through and you release all the ligaments here, and the eyeball can just sort of move forward, and you deliver the hematoma from right behind the eye. So that's that. This is then actually the reality of what mostly I did, especially back at base, is if you try to reach for the ground after you've jumped out of an aircraft, it's totally and completely superfluous. The ground will always reach for you. You don't reach for the ground because, as you guys can see, there was definitely an issue with this person. They had pointed one of their toes and tried to land on one foot like a ballerina. Didn't go well. And then this is actually us inside the gas chamber. That's the end of the CS right there, because none of the 4 of us would leave the gas chamber. That being said, this is more the reality of what you see in emergency medicine around here in Seattle. This is orthopedics gone wrong. That is a total knee arthroplasty that approximately 10 days out had catastrophic failure that was brought into us. This is a complete, so remember we were looking in Ava's presentation, looking at everything else inside the lungs. And so you're looking, there's your diaphragm right along the bottom, right there. And here is essentially a totally normal lung. And this lung has completely and totally filled in with fluid. This was a 78-year-old woman who had come in being really concerned about shortness of breath. We had gotten an initial chest x-ray that looked very, very odd, and then followed up with a CT scan. And then this is right here is a case that Dr. Pierre and I worked on, unfortunately, earlier, I think last year, where he had secondary to really high blood pressure, a hemorrhagic stroke. And so you can see otherwise relatively normal brain tissue here, but then brand new fresh blood, and then also some penumbra extending through there. And that's more what you do. So I balance that. I have 2 kids. I am super pumped that my one child is as excited about dress up as I am. And although she wore this yesterday for costume day and was far more excited about it. And I manage that. I work here. And I think most importantly, I get to teach. So I work with residents, I get to work with medical students, and I've had a chance now to talk with you guys. So with that being said, what questions do you guys have about emergency medicine? What do you guys think of it in terms of what it is? Can I dispel any myths? Can I tell you any more about sort of the nitty-gritty and the regularity of what it is? Sadie?
2 questions.
Yeah, go ahead.
How did the 78-year-old woman's lungs fill up with blood?
Here, I'll let you ask it again, sorry.
How did the 78-year-old woman's lung fill up with blood?
Okay. So she was on anticoagulants, and she was actually on warfarin. Her warfarin had gotten too high, her levels were. So it's based off what we call the International Normalized Ratio, or INR. So we look across here, if everybody in here, including myself, I'm not taking any anticoagulants, are going to assume our INR is going to be between 0.9 and 1.1, just based off of bell curve. We should all be just about 1. Hers was at about 5. And it happens, right? This is the issue with warfarin, right? This is the whole reason. And when I trained, that's all we had. All we had was warfarin. So if there was a bleed in the brain and they were on warfarin, I'm calling Dr. Pierre immediately. We're having to give large volumes of all sorts of things. Now we have what are called the direct oral anticoagulants, work on different mechanisms in the coagulation cascade, predominantly on factor 10, based on the ones that we use. And you don't see that huge range in the INR, and you tend not to see as many bleeding complications. With her, she developed a little nick, essentially on the inside of her lung, and she couldn't stop bleeding, and she just bled and bled and bled. Now, right, that's a extreme case, right? How many times have I seen that in 15 years of emergency medicine? Twice, right? But it's one of the things, and sort of the way you think about emergency medicine is I always have to assume worst case scenario. And so even if somebody comes in and they're like, I stubbed my toe, I'm like, oh, could this be, are you diabetic? Could this be a worsening infection? Could this be all sorts of other stuff like that? In reality, yeah, no, you most likely just got a toe fracture, and your ankle doesn't look like that ankle that I put up there, which is, a trimalleolar fracture that's going to need to go the next day to the operating room, unless, depending on your surgeon, or sometimes they wait 2 weeks to let the swelling go down. Your second question, Sadie.
What is the hardest thing that you have done in medicine?
It's talking with families, right? If you're seeing me, why do I hate motorcycles? Why do I hate ATVs, right? If you go out and have a great time on them or riding a bike or anything, you don't come see me, right? But a lot of the time, right, I'll never forget, I was at Harborview as a resident, and me and James Bell, who was the neurosurgical resident, same year, we were both third years, and so we were on, I was on as trauma doc, and he was on as the neurosurgical senior. And we had a 22-year-old that had been working on his car and the jack failed. And the entire weight of the vehicle landed right here, right? Catastrophic injury, right? He's still alive because his heart is beating. But we have to go into the room and you have to say, okay, hey, this is what happened. We are so sorry. But your son is going to be brain dead. There is nothing that we can do. And that's the hardest thing, right? Like the case that Dr. Pierre and I had. Yeah. It was talking with the family. Yeah. It's talking with, in that case, that gentleman was in his 80s. And so very different. But it's specifically with kids. I remember every single one. And I was taking care of an emergency physician the beginning of the summer. And she's an emergency physician. She was in her late 80s. She had really bad reactive airway disease. And so we're trying to fix her asthma and COPD. And after we got things better, we were chatting, and something that she said to me, and that I think is very true, is she said, we all carry a list with us. And it's a list of names. And it's those patients that you never forget. You'll always remember. And at least in emergency medicine, unfortunately, most of those are the patients you couldn't save. So, anywho, sorry, I didn't mean to end on a down note, but unfortunately, that's a large part of emergency medicine, too.
Any other questions? I'm sorry.
I have a question kind of similar and follow-up to that is, with all of that happening, what's, I guess, your method for still going forward with that? What's the thing that keeps you going in your field, even with all of that emotional struggle?
So it's a couple of things. I think that, the longer I've done this, the more I realize, there are different cultures in every single subspecialty. Then in every group. And try to be as true to yourself as you can, irrespective of, whichever culture that is. In emergency medicine, it's just do more, grind harder, go further. Doesn't matter. You see the next patient, right? And that sort of works briefly, and then it comes usually crashing down. And you see it in our colleagues. Like, how many colleagues do I know of mine that are alcoholics or in recovery, are now into multiple marriages. And so I think personally what I do is, I'm not afraid to talk about it. Have I had to do therapy in the Army? Absolutely, right? Like, I know August 21st better than anyone because that's the day that Jose Gonzalez and Luis de Leon Figueroa got killed in an ambush, right? That's the reason I wear my KIA bracelet. But they're not the only guys I've lost, right? When I think about March 17th, that's when Mark de Alencar got killed in an ambush, right? And it's because maybe I didn't enforce upon my two medics that I trained, hey, you absolutely have to be carrying X, Y, and Z, right? Probably not. Mark got shot in the neck. But I think the biggest thing is, I work through it. And it's never, it's one of those things I would argue is not a perfect process, right? So that's at least how I approach it. But I also know there are plenty of other physicians that approach it differently. And that'd be a good thing to ask because you're going to get a different answer every single time.
Thank you for being willing to talk about that.
No, absolutely. Angela.
So as we're all learning, different specialties and different areas of medicine can suit different personalities and all of that. And obviously, as in emergency medicine, you see a lot, you have seen a lot, and you will continue to see a lot. What would you say are good personality traits, characteristics, or talents that make one well suited to emergency medicine? So,
ability to talk to people, right? One of the things I love the most about emergency medicine, to jump back into your question as well, I love the times that we are, all the positives. And so I try to focus on that, right? It's hard the human brain is geared toward the negative, right? We are geared toward the negative because identifying the negative kept us alive. Knowing things, how they went wrong, being able to focus on that, okay, avoid that, right? But you try to look at the positives, right? Hey, I took care of a 7-year-old, I reduced the fracture immediately. Kid's gonna have an awesome outcome. We worked this belly pain up, maybe more than initially we thought it was going to, immediately caught the cancer early, got them referred into oncology. Oncology got to see them within 3 weeks. And now they've got a stage 1 diagnosis versus a stage 3 diagnosis, and I are automatically vastly improved. So I focus a lot. I personally focus on that. That's one of the things. Being able to talk to anyone, EM is very egalitarian, right? Everyone can come in and see you. You never need a referral. You just walk in the door. And I like that. And then I think the other big one is sort of then going on to that is stoicism, right? Like, you're going to see a lot of things. Like, what do I do after I finish the code, whether the patient lives or the patient dies? Unless it's the end of my shift, I see the next patient. The next patient may be there because, and I kid you not, they have stubbed their toe. And they may be upset that you did not see them rapidly enough. This is not me making it up. It's sometimes the reality. And you just say, okay, hey, look, you know what? I'm so sorry. I don't know. I used to say, hey, you know, we were in the middle of a code or I was coding a child. Like, come on, you gotta. I just say, you know what? I'm so sorry for making you wait. We're a little overwhelmed briefly, but I'm here right now. I'd really like to hear more about what happened, what brought you in, and what made you think that this is an acute emergency. You go from there. So I think that, you know, that's sort of stoicism, and that's actually, you know, I really got, I mean, if you want to deep dive, like I really got into like the thoughts of like Marcus Aurelius and like his meditations and sort of how does he, you know, move through it. What does Seneca think about all of this? There's a great book called The Obstacle is the Way. And like my colleagues are so sick of me quoting that at them, being like, when they're like, why would 7 people, and it's like, it doesn't matter. Like none of that matters. Like 7 people checking in at once, you know, like that's okay. You just got to roll with it. And I think that that's a big part of emergency medicine, for better or worse. You know, and it's just sort of that outlook on life. But does that sort of answer your question?
Yeah, thank you so much. I really appreciate your response.
Yeah. Okay.
We have some questions in the back. Can you tell us your name?
My name's Belize Orton. I was wondering, you did your residency at Harborview, right?
At Madigan.
Oh, Madigan.
Yeah.
What were your most favorite and least favorite parts of residency?
Ooh. So one of my least favorite parts of residency, we ended up doing block scheduling, which meant that as a senior, out of 365 conceivable night shifts at the mothership, which we ultimately called the Death Star, which was Madigan, I worked 95 of them. I had 11 other co-residents. So if you do the math, I worked slightly more than a quarter of all of the available night shifts. So that was a low point of residency. It's why now I work more nights, because I'm just used to it. Maybe I like nights now. I don't know if that's the way you should get into liking night shift or not. Maybe not. But some of the best parts of residency, actually, you know, I make fun of Durbin being asleep, and I've got photos of every single one of my attendings asleep at the desk, just in case. You never know when you might need that. But is the independence, right? Like, well, I could be upset about it. Like one of the other attendings that was in there, Will, like he would always just be like, if we were slowing down, he'd just start signing you up for patients. You'd be like, sweet, I'm feeling pretty good. He'd be like, well, you've got these 3 other patients you haven't seen yet. And I'm like, no, I never signed up for that. He's like, oh, look, your name's on it. Cool. Right, and it's that, you know, it's very hard, it's very challenging, because, you know, at that point in your career, you're just trying to figure out, you know, like, what in the world's going on, like, pathophysiologically with that patient? Like, why are they here? But it's that, you know, that sort of, at times, even though it can be really painful, that makes you a better physician, makes you better at handling the stress, sort of stress inoculation, so to speak. So.
And how many years did your residency take?
3 years. So emergency medicine, depending on the programs, all the military programs are 3 years. And then actually out here on the West Coast, it's a decent mix of 3 and 4 year programs. But then especially on the East Coast, it's mostly all 4-year programs. Biggest 3-year program out here on the West Coast is Stanford, which is still a 3. But like University of Washington, for example, is the only EM program in the whole state, and there are 4. So.
Oh, sorry. I'm Cassidy.
Hey, Cassidy.
I was wondering, what made you choose emergency medicine rather than just like doing trauma surgery?
Yeah. So that was the big, for me, those were the two, was whether I was going to do a general surgery residency or emergency medicine. And in part it was because by the time I was finishing residency, or actually starting residency, I was already in my early 30s. And so I was trying to figure out, hey, like if I had done trauma surgery, I wouldn't be getting out of being an attending until I was already in my early 40s. And so I looked at that, I looked at lifestyle. And while I can still argue that at times lifestyle of emergency medicine can be really challenging, just because you're always working a different shift, or at least at this group. So like when I gave this talk, the first time I was coming off of 3 night shifts in a row after I had worked a weekend of day shift and the previous week of fully night shifts. So you're always flip-flopping back and forth, which can be really difficult. But I felt at the time emergency medicine was slightly, my partner and I were thinking about getting married, we're thinking about children, all of that. And we felt that just overall it would be better lifestyle as compared with trauma surgery. I've one of our good friends from medical school was trained at University of Washington and then went to Denver Health for trauma. She loves it. And her partner is an orthopedic hand surgeon, and you make it work. So I wouldn't say, oh, trauma surgery is totally, you won't be able to have a family. Not at all. You can make it work. It just, for me at the time, it wasn't something that we felt was going to work. And I loved emergency medicine enough. I had done enough time in the ambulance in Baltimore that I liked it. And there are other aspects of it that I really enjoyed. I loved just the breadth of it. Although with general surgery, that was one of the other big things. I didn't think I could do something more focused, for example, like what Dr. Pierre does. And I think that sort of swings back to Angela's question of sort of what are other personality subtypes, and the slightly hypomanic ADHD personality subtype is something that you see a lot of in emergency medicine, because you get done with one problem, you move right on to the next one, and the next one, and the next one, and the next one, and then you're always off on a tangent looking for something else. And that sort of task switching is something you see a lot of. So
if that's all the questions, again, we thank Dr. May. We'll have all the students come up and do our photo op.